I'll catch up with the time. There are certain slides which probably you would know more than I do. They are the different causes. You can classify them into different ways, whether it's scarring alopecia, non-scarring alopecia, whether it's because of the certain deficiencies of certain elements in the body, or it is because of medicines, because of other diseases. So it could be divided into so many things. I'll just quickly browse through them. And once you go through that, which are the causes, we come to the main thing, which is androgenic alopecia. There are two other things which are quite confusing when we talk about the hair loss, and the three of them, the androgenic alopecia and acute telogen effluvium and chronic telogen effluvium. These are the three things which actually comprises of about almost 80, 85, 90% of the hair loss in female. And you need to understand the difference between the three of them, because they more or less present the same way. The age group is the same. The only thing is when you do the examine the hair, you will see in one of them, which is androgenic alopecia, the ratio between the terminal hair and the vellus hair is reduced, which is less than 4:1. The normal is about 8. Whereas, and the other thing is that you will see that most of the hair are in the same phase. Their diameters and everything is in the same phase. So there is not much variations in that. This is really, and when you do not remember your slides as well, so you can't speak much on that. So sorry. Alopecia, non-scarring alopecia, we can have it into dietary deficiencies, hormonal imbalance, drug-induced. It can be a telogen effluvium and anagen effluvium. It could be autoimmune disease, and it could be collagen vascular disease. So these are all how you can actually classify the hair loss into. But what we're going to mainly concentrate on is the female pattern hair loss. This is the normal hair cycle, which has got the anagen, telogen and catagen phase, and there are a couple of other phases, which is exogen and that. So anagen, as we all know, it is the phase of active hair growth, and 80 to 90% of the scalp hair are into this one. It varies from 1 year to almost about 10 years. The longer it is, those females or those individuals who have got 5 feet long hair, the anagen phase is about 10 years, and that is why it is. And some people have got 4 years, so they can't grow their hair longer than 2 feet. Then this is the catagen, which is actually an involuntary phase, and over here the hair follicles start involute and then go into telogen phase, which is actually a resting phase. Then there is exogen phase and kinogen phase. Exogen phase is a controlled active process of shedding of the hair fiber. Unlike previously that one hair is coming out, so it's pushing the other, is not there. And then there is a kinogen, which is actually the time where there is no hair follicle over there. The most important when we talk about androgenic alopecia is the testosterone, which changes into from the 5-alpha reductase to dihydrotestosterone. It works on the androgen receptors, and that is when you have the hair loss. Now, the molecular basis is divided actually into two things, the genetic factors and the environmental factors. And most of us who ignore environmental factors, if you address that, you will actually be able to give them a significant improvement, and that mainly goes through the inflammation, whereas the genetic factors are either androgen axis, it could be different signaling sort of things which actually affect at the very topical time, and then there are neuropeptides. And it changes into what we call as miniaturized follicles, so basically from the terminal hair into the vellus hair. This is the multifactorial pathogenesis, which includes the diet, the lifestyle, the microbiome, the scalp environment, and if your food and dietary and sleeping habits are not good, it started to cause a chronic inflammation. There is testosterone-estrogen ratio imbalance, which leads to increase in scalp dihydrotestosterone, androgen preceptors, and there are some calcification regulators, which is imbalance, which leads to calcification, fibrosis, blood supply is low, so there is low oxygen and hair loss. So if we know that we have to address something like blood flow, so if blood flow and oxygen can be improved, we can actually improve the hair, right? So we need to understand all these small little area, and that is why, and this is something else. These are all signaling pathways. So if you have got a WNT pathway, if you have a hedgehog pathway or STAT pathway, these are all pathways which actually affect this. Now, a lot of research is going on into the pathways. Rather than androgenic alone, it is the pathways which interfere with each other, and that causes a lot of hair loss. So in the recent time, for the last, let's say, about a decade or so, there is a huge research going on into these pathways, and there are some treatments which are addressing it, and what our aim is to reverse that miniaturization process, which is actually affecting at the anagen phase. So our treatment is based towards the anagen phase to prolong the anagen phase. So now you need to understand this thing. Dr. John Cole, he has shown that if the diameter, which is normally between 70 to 90 microns, if it is reduced by 10 microns, which is 0.01 millimeter, right? The effect, the visual aspect of that is almost about 36%. So that is how important it is that if you change your anagen phase, which is miniaturization, you prolong it, you can actually give a visual illusion of 36% without increasing the number of hair. So when we are evaluating the patients, we need to do the history examination, hair pull test, histopathology, microscopy, blood chemistry, and ultrasound in order to see that. Now, again, you need to first exclude whether there is a scarring or there is a no scarring. If there is a scarring, you need to do the punch biopsy. You need to see whether it's a hereditary disorders or it's a trauma. If the biopsy is negative, if the biopsy is positive, then you need to see whether it is discoid lupus erythematosus, sarcoidosis, lichen planus, and all those cases. Maybe it could be fungal or it could be neoplasm, so you treat them accordingly. If it is absent, then you want to do the testosterone, free testosterone, DHEAS, prolactin levels. You want to do all others, ferritin, ANA test to rule out systemic lupus and all those things. So that is how you really want to work up and see what is the causes behind it. Right. One of the most challenging one, as I said, is the TELOGEN effluvium, which is actually an abrupt onset and it's self-limiting. Usually if it lasts more than 6 months, it can go into the chronic TELOGEN effluvium. You have to really differentiate. I'm just going to skip few ones just to catch up with the time. The most important part over here is that you want to do the dermoscopy and biopsy, which will help you and tell you what is the difference. In biopsy, you would have something like the TELOGEN effluvium and terminal versus the vellus is reduced. It is less than 4:1, which is diagnostic. And on the other one, it is normal between 8 and 4. When you are doing dermoscopy, you want to see that there is a marked variation in the shaft diameter when we are doing the androgenic alopecia, and the difference is not there when it is either chronic or acute TELOGEN effluvium. So this is the maximum number of patients would present over here. So if you can exclude the androgenic alopecia, you are left with the acute and chronic TELOGEN effluvium, which will need a little bit more workup. If it is acute, you need to be a little aggressive if the history is less than 6 months. This is the pull test which will tell you if it is telogen effluvium or if it is not. It should be at least 10% of the total hair pull test. Now, coming to the treatment options. It can be a combined medical and surgical treatment. For female, usually I prefer to have a strategic or camouflage hair transplant, which mainly covers the front part of it, and the rest of it, I want to use some sort of medical, support. Along with that, maybe some fibers, camouflage, recently maybe SMP, scalp micropigmentation. But this is how it is. If the patient is premenopausal, you want to see what it is. So probably you will put them on 5% minoxidil with finasteride or spironolactone, or you will, if it is, there is no evidence of hyperandrogenism or PCOS, then you can counsel it, but 5% minoxidil. PRP, you can always add to all of them. Lasers, as this is a laser session, low dose laser therapy does improve a lot. If it's a post-menopausal, it's mainly again minoxidil, finasteride. You can use few other treatments. We'll come into that thing. This is a study which was, there were a few studies, but the last one, which is EON in 2011 with almost 87 number of the people, one of them actually pulled out due to the headache. The other 86 have shown that there is a significant 81.4% improved in that thing, and this is all pre and post menopausal patients. So finasteride 5 milligram daily dose actually helps them, improves there by 81.4%. This is that study. Our goals, as I said, is increased blood supply, more follicles to enter into the anagen, prolong the anagen, and healthier scalp. And you can see that minoxidil can actually do all the 4 of them. So that is how it is. But the problem with the minoxidil is in the first 2 or 3 months, there is an excess of the hair loss. So you have to be with your patient during that time. And the main pattern is that it increases the blood flow, gives you more nutrients and oxygen supply, and hence that thing. There are a lot of people who confuse that if I stop the minoxidil, I'll go worse. It is not like that. Actually, when you stop the minoxidil, you will see that it will come back to the natural progression. But what you call is the vector is so steep, you feel that you have lost a lot. So you have gone worse. But actually, you have not gone worse. And if you start again, you will go back to that thing. So I think everybody should be going into or put onto the minoxidil. Now, the other is DHT reduction, which is the second line treatment. You need to understand how to address this dihydrotestosterone levels, right? In order to reduce that, you can either have to increase the metabolism, you have to reduce the free testosterone, you have to reduce the 5-alpha reductase, and you have to reduce the androgen receptors like that. So if we go into individual, so this is what it is. If you want to reduce the DHT, by reducing the free testosterone, you have to either increase the androgen binding proteins or reduce the total androgen productions. And for androgen binding proteins, what you need to do is this S-equal, which is basically from soya. So you can actually use that thing and it will help. Otherwise, for the rest of them, metformin, you can use it and you can use corticosteroids, which will reduce some inflammation. If you want to reduce the androgen receptors, the first one we have already done. The second is reduce the androgen receptor expression. Now again, the oxygen is important, and that is why some people, when they inject the ozone into the scalp, it improves the hair growth. So that is what it is, and the reason is because of this. If you want to block the androgen receptors, it is either anti-androgens like spironolactone or flutamide. Spironolactone, it works, it's like potassium sparing diuretic, so you have to keep an eye on the potassium. There are some, these are mainly the off-label treatments. That means it is not an FDA approved, so you have to be very careful with that. And when we are doing anti-androgens, we can use either Oler, which is finasteride, topical tretinoin. We can use as a shampoo, which is ketoconazole, and we can do treatments which competes with DHT for binding. When we are talking about 5-alpha reductase, which directly inhibits, and stops the DHT, so we want to use finasteride and dutasteride and zinc. These are certain patients before and after who have been on the finasteride, and then when we want to improve the DHT metabolism, we want to use certain enzymes like sulforaphane, and this is probably in broccoli.